Non-invasive hair loss treatments have changed the approach to managing hair loss, offering patients a breadth of options beyond traditional hair transplants. Dr. Alan Bauman, a well-known hair transplant surgeon based in Boca Raton, Florida, stands at the forefront of this transformation, integrating cutting-edge technologies and treatments to craft personalized hair restoration plans that cater to the unique needs of each patient. Non-surgical hair loss treatments encompass a variety of in-office procedures and at-home care strategies, each with its own merits and applications. To discuss this and the different non-invasive approaches, I am thrilled to have the opportunity to delve into the nuances of various non-invasive hair restoration techniques with you today, Dr. Bauman. So welcome.
Thank you so much, Hannah. It's great to be with you.
Thank you. So let's start off by just discussing that it seems that we're beginning to uncover the full potential of non-invasive hair treatments, as I mentioned earlier, and their efficacy for our patients. Do you think that we are still in the early days?
Well, I think we've come, first of all, so far since I've been in practice, over 25 years. In the early days, we really didn't have much of anything. It was, topical Rogaine, and then, of course, finasteride in the form of Proscar, and then Propecia was FDA approved. But so many changes, so many advances have come about, whether it be compounded medications, low-level laser light therapy, regenerative treatments. I mean, it just seems that things are progressing so fast that I'm very optimistic for the future, that we're going to have so many new therapies and treatments. We just got to hold on to the hair that we have right now, if we want to take advantage of those therapies as they come, as they come to us. But yeah, I think that we're going to see a lot of breakthroughs within the next couple of years, especially in the realm of regenerative medicine.
Which is very exciting. So how crucial is it to include non-surgical options such as in-office procedures in a comprehensive hair loss treatment plan?
Oh my God. Well, that's the key to the whole thing, actually. Prevention is the number one thing that people should be thinking about, especially if they're at risk for male or female pattern hair loss, which is the most common types of hair loss that we treat. Obviously, there's hundreds of different other things that could happen, but we've got to get on the treatment quickly. So we always say in the field of hair restoration that time is follicles. That means that every day that goes by without therapy or treatment, this chronic and progressive condition is going to get worse. And we actually know how much worse it's going to be. I mean, if you look at the placebo arm, for example, of the finasteride trials back a number of years ago, 20 years ago, I mean, 75% of people look much worse in 5 years. That's not a good plan. You don't want to look worse in 5 years. You want to look hopefully better, or at least the same. So non-invasive therapies are critical, especially in the early stages of hair loss. And in my practice, I think we have many patients that come to see us in early stages that may never, ever need a hair transplant, because we're starting them on therapies and treatments so early, both men and women. And patients who have had procedures may never, ever need another procedure, another transplant procedure, because we're holding on to the hair that they have for the long run.
So is there like an age you would say, or a time at which you would say that someone should come see you?
Well, I would say that as soon as you know that you're at risk for hair loss, and you're cognizant of it, I would say, let's take a look and see what's going on. Even some baseline measurements can go a long way to track over time, because we know through science and research that you can lose 50% of the density and it will still look about the same to the naked eye. So if you have a balding crown, or even a woman with thinning hair in the front, it can look pretty good up until you lose 51% of your hair. And then all of a sudden, oh my gosh, it's starting to look thin. So there's this interesting and unique opportunity. But for both men and women, it could be different. For men, usually right around puberty. After that, that's when male pattern hair loss starts. So that's a good time to do some baseline measurements. We do AI-powered microscopes, look at density and hair caliber. We can do hair check trichometry. That's a bundle measurement. And that helps us develop a baseline. So we may not initiate any therapies or treatments. We may look at your genetic risk or lifestyle factors and see what's going on. For women, sometimes it happens in and around the years of childbearing age, like childbirth or PCOS, common conditions. But more commonly, we see in women, it's around the time of menopause. So perimenopause, menopause, and postmenopausal women typically notice some big changes in their hair. Not just the amount of it, but obviously color, quality, texture, and other issues can occur too.
Right. So, could you walk us through what the typical process for evaluating one of your patients and selecting the most appropriate hair loss therapy for them? I know it can
Absolutely.
range because obviously there are different causes of hair loss, but I would say on average, what does that look like?
Yeah. So, I mean, this is something that's evolved quite a bit over the years. I mean, I already mentioned some of the measurements, but before we even get into that, we're looking deeply into the patient's history. So, I mean, it seems like today it's not so common to listen to patients, right? But this is really important. You have to interview the patient. You have to get their medical history. I want to know about close relatives with hair loss. Is there male or female pattern hair loss? What are their hair styling habits? If it's a woman, are they using a lot of chemicals and heat? Are they using a Brazilian blowout? What are their symptoms? Are they having an exacerbated shedding problem that happens maybe every year, same time of the year? Or is this something that happened a couple of weeks after a cosmetic surgery procedure, like, for example, general anesthesia can cause some shedding? Or is this something that's gradually evolving over time? So getting the medical history and the hair loss history is really a critical step. And then what I found is the other component is the lifestyle factors. So are they on a special diet or weight loss program or have had bariatric surgery? That obviously impacts their nutritional intake. And because the hair follicles are so highly metabolic, in fact, they're the highest mitotic rate of any cell population in your body. That's what they tell us, that the cell divides in the hair follicle quickly and more prolifically than any other. It's such a strong barometer of health that if something's going on with your nutritional status or your absorption, for example, or even if you're stressed out, you're not sleeping, your sleep-wake cycle is out of whack, or you're on certain medications, that can influence your hair follicle function as well. So I would say, I mean, a holistic approach, a 360-degree approach to the hair is really important. And we uncover so many different things. In fact, I found so many metabolic disorders over the course of 25 years and 33,000 patients that I actually put a functional medicine practitioner inside my office. And I have an entire department that deals with only those issues that we uncover when we're investigating hair loss problems. So the hair follicle, I would say, very sensitive organ to a lot of different things, and that's why we want to really get an overview of what's going on. And once we've done that, then we're on to what I would consider the testing, right, or the evaluation. So we're looking first at the hair. Is it smooth? Is it shiny? Does it look normal? Does it look broken? Does it look dull? Is the scalp dry? Is it flaky? Is it inflamed? Is there folliculitis or pimples developing on the scalp? Is there any symptoms of pain or tenderness there? We want to look at that and figure out what's going on. What is the hair styling regimen and habits? What kind of shampoo and conditioners are you using? How often? And are you using them properly? Oftentimes, we find that patients are not using their conditioners properly. And then we're looking at their hair density measurements, right? So how much hair is in each zone? The more permanent zones towards the back are going to have higher density, higher caliber. So as we look into the areas that are typically at risk, we're going to see weaker quality hair density, weaker quality hair caliber, and also probably shorter hairs. And that's the pathognomonic sign of male and female pattern hair loss, this miniaturization that occurs over time. And then we want to find out what they're trying to accomplish and what they've been doing in terms of therapies and treatments. And of course, we talk about hair care and scalp hygiene if that's an issue. We look at nutrition and the lifestyle factors. We talk about medications like finasteride, minoxidil, other treatments that are anti-androgen therapies like for women spironolactone or men dutasteride if we want to get more sophisticated, prostaglandin analogs, for example. And then red light therapy, low-level laser light is a big part of our practice today. We have in-office devices, at-home devices that are very, very powerful, and the regenerative treatments. So all of that is like fertilizer in the garden, right? Keeping the existing hairs growing strong, taking a look at what's going on. We could backtrack into DNA testing to see what metabolic pathways they're more prone to either getting a result from a treatment. So maybe we should direct treatment one way or the other. Or if they're prone to nutrient deficiencies, for example, nutrigenomics is a great new burgeoning field, which I love to delve into with patients. But the idea is to hold on to the hair that they have so that they don't need a hair transplant. But if the follicle density is weak, then we have to talk about things that will go way beyond the regenerative capacity of PRP, platelet-rich plasma, PDO, exosomes, stem cell therapy. We have to talk about minimally invasive transplants. So that's kind of the whole ball of wax there, Everything that we do here at the hair hospital, well, with the exception of like, cranial prosthetics, which are, non-surgical hair replacement options, we do that too. But in terms of the medical side of things, that's kind of the menu
Okay, so
and the algorithm.
we're gonna unwrap each one of those. I do want to ask you, do
Great.
you typically do blood work for each patient that comes in?
Well, not every patient needs blood work. But, again, I've always been taught, and maybe I'm more traditionally trained allopathically, many years ago in the 1990s, where we were taught to, talk to the patient, and that gives us a diagnosis like 85, 90% of the time, and then do the evaluations that are required. Right, not just a whole battery of every single test that's
Right.
possible under the sun, which seems more like a CYA medicine, today that we typically get. So yes, very often we'll do blood work, especially on our female patients who have hormone imbalance or have been diagnosed with something previously, or men who are on hormone replacement therapy. I want to know where their testosterone levels are and their other factors that could be influencing their hair. If I'm suspecting PCOS, of course, we might send out for some different things and testing, ultrasounds and such. But having a functional medicine department, to really take a very close eye on all of those things, has been really, really helpful. And that happens in parallel, right? Because we're not going to wait for your blood work to come back to start to
Right.
treat your hair loss. But that will hopefully elucidate some things that we can tweak and modify that will eventually get you better hair growth in the long run.
And do you find that patients are asking you for a diet? I find with many things in skincare or dermatology, people are like, well, can you tell me what I should eat, what I should not eat, so I can keep my skin looking nice or avoid pimples? So I'm curious if you find the same thing in your patients with their hair.
Well, again, through a medical history, we can figure out kind of what's going on. So if a patient says, well, I'm on this caloric restrictive diet, or I've been started on a semaglutide or, Ozempic, whatever, I've had gastric sleeve, we know that they're going to be nutrient deficient probably. And that's why the reason why they've lost the weight. And so are they protein deficient? Because you need protein to grow hair, end of story, period, full stop. But there may be other things that we can figure out by doing the blood work and looking and seeing, what do we need to enhance? And so there's no one size fits all. This is the diet for hair regrowth, but look, if you're protein deficient, if you're iron deficient, if you're mineral or vitamin deficient, you're going to have a harder time growing good hair, and your response to treatment is going to be different.
Right.
Vitamin
So,
D is a great example of that. Vitamin D has been linked to hair loss sufferers. And so, and I think what do they say, like 99% of people are not in the optimal range for vitamin D. And that's not just for the pandemic, by the way, years ago. That's for everyday life.
maybe not so much in Florida, but but
No, we
yeah,
have it. Unless you're a surfer, typically if you're working and you're not like a, retired or professional golfer, you're going to need, you should try to get some sunlight for sure. But, a lot of our Floridians, I'm probably one of them. I need vitamin D supplementation. I'm working hard. I have 11-hour
yeah.
days. I see the sun through the skylight.
At least you won't get skin cancer. So, I
Okay.
want to
That's
go
good.
through this long list of treatments that you offer in your practice. Let's start
Okay.
by first talking about TED, which stands for Transepithelial Disruption. Could you explain to us this technique and what you hope to accomplish with TED? Because I know in the past
Yeah.
you were a big advocate for microneedling with PRP, and are you still doing microneedling with PRP?
Yeah, so I'm very excited on TED. TED stands for Transepidermal Delivery, and it's kind of a combination of something that's old with stuff that's new. And what I mean by that is that we can use a technique called sonophoresis. And years ago, this was called phonophoresis. Back in the 1950s and 60s, orthopedic surgeons and orthopods were doing sono or phonophoresis to drive corticosteroids into the knee without a needle. And how did that work? Well, it was the use of ultrasonic sound waves to break the stratum corneum, to disrupt the stratum corneum, to allow penetration of large molecules. And so what kind of large molecules would we like to deliver into the scalp? And this is where the new technology comes into play. We have new growth factors and peptides, things like copper tripeptide, VEGF, we've got a thymosin beta 4 derivative. These are all, and also amino acids and a few other things in the mix that can be really helpful for hair regrowth and maybe even hair repigmentation in some cases. So the way that TED works is super exciting because it's non-invasive. No needles, no pain, very relaxing. And I've had it myself. So I can tell you firsthand, I just did another TED session about 2 weeks ago. Very relaxing. And so what TED is a device that basically emits that ultrasonic sound wave to the skin. And there's a preparatory phase where the skin is treated first with just the tip of the device. And so that starts to break up the stratum corneum or disrupt it. And then we apply that special serum called the TED Hair Care Plus serum. And then we use the tool to drive it into the skin. So there's a kind of a pressure wave at the same time that there's the ultrasonic disruption. And that combination drives the serum deep into the skin, and it stays there for a long period of time. There's actually a lot of good research on that I've presented in many of the international conferences in medicine and cosmetic procedures, and actually even in the International Society of Hair Restoration Surgery last year. We did our pilot study, and I presented the data on that. So the point is that what that does is that if there's a hair follicle there, we get a regeneration, a reboost, if you will, of hair fiber production. So it can stop shedding immediately. It's one of the first things that patients notice. And they get some hair regrowth from those weaker wispier hairs growing longer, thicker, and actually darker and stronger in some cases over time. So it's different than PRP in my practice, because PRP, the way that we do it, is a once a year bit of business. TED is a series of 4 visits, once a month for 4 months. And then we measure you. So we measure you before and then after the therapies, and that at appropriate intervals, usually approximately every 90 days, to see when you have your peak and plateau from a treatment and then when it starts to decline. And then we can decide, do we need to do another TED treatment? Are you doing it also with PRP intermittently? Are you adding it to other therapies or treatments? Things like that. But yeah, TED is great. It's super exciting to use the transepidermal delivery system.
So the patients on TED, are they also on oral medication
Well, in the
for
pilot
hair
study, it was
loss?
pure. Well,
Okay.
in our pilot study, the answer would be no. Of course, these are pure patients. They're not on any other therapies. There's a washout period, or they're virgin patients, so to speak, when it comes to hair loss treatments. And those patients did very, very well. The first dozen patients we did had a spectacularly visible result everywhere we treated them with the TED, which was great. And we tracked their density and hair measurements over time. So it's been pretty cool. But our traditional patient is throwing everything but the kitchen sink at it, as you probably know.
Right.
Since TED is so new, most of my patients, I have 35,000 patients, most of them have been on other things, and probably still are, whether they're continuing to do PRP annually, or they're doing other treatments at home, like topical medications or oral medications or laser light therapy. They may be just adding TED to try to get a better result from those other treatments, since it's not a redundant therapy. These growth factors and peptides are not something that's been available really before. And it's not something that penetrates the skin all that well. Some of these molecules are quite large.
And do you find that you've had to do maintenance, or you're not there yet? So you don't have you got to the 4-month period, and then you kind of let them percolate and sit and see how they do over the next year? Have you I'm not sure if have reached this point yet, but have you said okay, maybe we're gonna have to do a maintenance with TED every year or every other year?
We do find that that is the case. We've been doing it for a couple of years now. So we already know that, first of all, there's a lot of variability, right? I see patients from 18 to 88 or 108, as we say. So there's all ages, men and women, different types of hair loss, different stages of hair loss. And so they're all in a different part of their journey. So for some patients, I have patients, women who come in, they sign up for just once a month, every month. They just do it as part of their skincare routine. So they go, okay, I do my skincare, I do my scalp care. And they just love the feeling of it, and they love the results that they have, and they don't want to wait for it to decline. They just want to keep it going.
Right.
And in many cases, more is better in terms of TED. But usually we'll do that package of 4. That's what's getting us an average of 20% to 50% improvement in each area, which is really, really nice in terms of thickness and fullness for most of these patients. Sometimes they have to repeat a series before the end of the year, so it's not lasting a full year in some patients. But other patients seem to be doing great, well beyond a year with that regimen. So we'll
Very
have to wait and
exciting.
see it's a very cool treatment, to be able to provide something that's non-invasive, that's, has no side effects. that's just really simple and easy to undergo. Obviously, for the practitioner, you need to invest in the technology, and you have to have appropriate training to apply it. But it's a very cool thing to add to the practice, Ted. And a lot of my colleagues, after my presentation in New Delhi this past year, have added it to their practice. So we're seeing more and more Ted for your head providers, as we say on social, coming available.
So, how do you compare TED to the low power thulium laser treatment, or even to the hydrofacial Caravive treatment?
Yeah. So personally in the practice, I don't use the thulium. I have heard of it. Many of my colleagues have presented on it, and they seem to be getting adequate and good results with it. So, I'm not the expert in that particular treatment, but we do use the Caravive. So the Caravive is the hydrofacial device, but it's fine-tuned to apply a hair growth serum, if you will, to the scalp. I will say that we use the Caravive more in our trichology department. Trichology is where I have my certified trichologist who takes care of the health of the scalp. So people who need like continuous exfoliation, maybe once or twice a year or more often than that, if they have a specific scalp health issue, whether it be folliculitis or inflammation, some of our frontal fibrosing alopecia patients are undergoing treatment in my trichology clinic using medical modalities in combination with serums and different services that we provide in the office. So I would say the Caravive fits more in that scalp care regimen. But the good news is that many of those patients, once you clear up the scalp health issue, all of a sudden the hair seems to flourish. And it kind of makes sense, if the soil is like, not so good, you're not going to grow good plants there. And so, aren't we all just like, glorified gardeners, I guess, agriculturalists? I don't know. How's your green thumb? But,
Your
it's
hair's a
important.
garden.
Yeah, for sure. And so, sometimes I got to fertilize it and sometimes I got to replant it. That's how it goes in the world of hair restoration. But my team does love the Caravive system. Hydrofacial has been very, very good for those specific conditions. Now, if you have severe scaling of the scalp, you might need something a little bit more specific, like a jet peel, to accomplish the same goal. But for the average everyday person, the gunk that comes off of the scalp is, it's pretty gross if you've ever seen it.
I think I'm coming in for a treatment. So, how do you find that that more females are getting these non-invasive procedures because that first off the medical therapies that are offered come with a lot of side effects, more so for females than males that could be potentially, of course, dangerous, especially if you have a history of
Yeah.
breast cancer.
So what I've seen in the practice, very, very early on, more than 20 years ago, the patient were primarily men. We didn't really have great technology for women. Even transplants were not really appropriate at that time because they were more invasive. Our instruments were really not necessarily small enough to get between the existing hairs all that well. So, hair transplants have changed a lot. So I think what we've seen over the years is two things happening that's benefiting our female patients. Number one, we're really, really keen now on preventative and regenerative treatments. Obviously, you heard the list. There's so many things that we can do, hopefully, before hair transplants are needed. And especially because women tend to lose their hair more diffusely rather than the recession of the temples, which happen maybe later on or due to hormone replacement therapy. So in those earlier stages, we have a lot more opportunities now for non-invasive treatments to work, especially if they're keen on coming in and getting measured, right? And then, so we can elucidate what's going on. The other thing is that in hair transplant procedures, our instruments have gotten so much smaller that now we can accurately and safely get between the follicles of a woman with diffuse thinning process. And that was really never possible, more than a decade and a half ago. It was really unusual. And so if surgeons have upgraded their tools and their techniques less invasively, then more and more women are going to have great results with transplantation and less, side effects or issues or complications afterwards. But you were asking about specifically medications. Well, medications were more geared towards men. I mean, look, Rogaine for men was out for how many decades before they decided to make something approved for women? I mean, it was terrible, even though we knew, and the women knew also, even in the early days, that minoxidil was appropriate for them. It just didn't have the clearance. So I
Right.
remember when Rogaine first got FDA approved for women, it was like, groundbreaking. But we already knew.
And they
But
obviously
anyway,
approve the smaller dosage.
originally, yeah. Now
Yeah.
now the 5% I think is approved as well. So
Yeah.
that's kind of nice. I think the game changer for women really has been oral minoxidil, in my practice at least. Certainly, we've been using it, for over 10 years, but not as a first line therapy. I think the New York Times study kind of changed the game globally in
Hmm.
terms of the demand for minoxidil. I heard that there was once upon a time, a year ago, maybe a shortage of oral minoxidil, at least here in Florida. But we use a compounded version. We start with a microdose. Typically for our women, they're not going to see side effects if they're dosed appropriately.
Hmm.
And they're going to get some pretty good hair growth. In fact, they might need laser hair removal. It's getting so much hair growth in all different places. But that's been great, and especially in conjunction with other things like red light therapy and so forth. Postmenopausal women, I don't have any problems using anti-androgen therapy freely for them as an off-label treatment. We use a lot of finasteride, dutasteride, orally and topically, or both together. Spironolactone certainly is a little, I think, in my opinion, maybe a little bit weaker than the finasteride, dutasteride. But those are certainly great options for postmenopausal women. Women in childbearing age, we have to be a lot more careful, as you've said. So, we don't want to create any problems with women and a developing male fetus, even though that's never ever happened. There's no record of anything happening. That's obviously a risk when you're blocking the DHT from being produced, inhibiting DHT production systemically in a body, but also in a developing male fetus. You need DHT to make men look like men, essentially. That's the idea, right?
Right. So, are you still doing microneedling and PRP, or has TED kind of replaced that?
Well, so that's an interesting question. We still do a boatload of PRP, and microneedling, as you mentioned, is a piece of that. That's kind of like the finishing touch, if you will, the icing on the cake when we do a PRP treatment. I have a room that's exclusively dedicated to PRP and regenerative treatments like that, plus PDO, which are the threads, and also exosome therapy. We can also apply with the TED, by the way, or without. So I thought when I got the TED procedure, I didn't know if it was going to replace PRP or not. I didn't know if it was going to decrease the amount of PRPs that we were doing, but everything is increasing. So I can't say that we're doing less PRP. I think more people are excited about a no needle treatment. So that kind of drove a lot of people into the practice. And I was excited about that. And to be able to get them a great result with something like TED was nice. So yes, so our standard PRP, which we've been doing for many, many years, over 12,000 treatments, over 16 and a half, 18 years almost, is 1.5 million platelets per microliter, 7.5 cc dose. And that treatment is injected carefully through the scalp after a ring block has been applied. We do not want to create a stress response in the skin of the scalp in the patient. So we do use a very robust, painless ring block application in order to apply that dual spin PRP. So it's a platelet dose that I mentioned of probably about 12 to 14 billion platelets plus the monocytes. And microneedling follows. We also use some growth factors topically at the time of the microneedling. And so it's a very robust procedure. Oftentimes we'll combine that with a perinatal biologic as well, an implantable one. And that's kind of the boost that gives the patients a year's worth of growth from our standard PRP.
And how often are you having those patients come in for
Oh,
that particular
yeah,
treatment?
yeah. So since we abandoned the gel separator test tube, more than a decade and a half ago, what we found is when we went to the dual spin process and the use of the extracellular matrix products, that we could get 10 to 14 months of boost with the correct preparation and deployment of the PRP. So of course, every patient is different. It is a bell curve. We've mapped it out for our patient base. 90% of our patients need PRP at about 10 to 14 months. And so that means the time where they're just coming off the plateau from the boost in terms of the measurements before they dip into the downslide. If they're already on the downslide, they can still look great. But we don't want them to go back to their baseline. We want
Right.
to keep them at that level, that plateau level, obviously, that we achieve with the PRP and other therapies. Some patients will get 18 months of boost, especially when we add in synthetic extracellular matrix like polydioxanone threads into the process. That's very popular. We've been doing PDO for a number of years, probably about 6 or 8 years now. Thousands of those treatments with very, very nice responses and extended length of time. And then, of course, there's those unfortunate folks. 5% of patients do need it more often than 10 months. So, they may have a more aggressive hair loss problem. They may not be so compliant or using other therapies. They may be just, dealing with more significant metabolic dysfunction or nutritional dysfunction. And we really got to push harder on them, meaning that those PRPs need to be done sooner rather than later for them. But it's always cool to see like some of the results lasting almost up to 2 years with a single regimen.
Very impressive. So I just want to ask you, so say a patient comes in and they've really never been on oral therapy and they haven't had any non-invasive therapies either. But they are like, Dr. Bauman, I want a hair transplant. That's what I want. Do you have a protocol where you like to start them either on oral therapy and combine that with some non-invasive therapies before approaching the hair transplant discussion?
Well, that would be very unusual because obviously in my practice, we push out a lot of information and education about male pattern hair loss. So that would probably be more of like a cocktail party discussion. Like someone comes over to me and says, "Oh, I really want a transplant." And then we say, "Well, what are you doing to stop the progression of the loss?" And they're like, "What do you mean?" But by the time they get to see me in the practice, it's kind of self-selected that, of course, we're going to protect your existing hair. It's like, going to a dentist who's just drilling your cavities, but not teaching you how to brush your teeth. I don't know who does that these days. Nobody.
Right.
So if you've gone to a clinic and the surgeon is just jumping into a hair transplant procedure for you and didn't spend a minute or more than 5 minutes talking about non-invasive therapies, I would say you need to turn around and walk away from that process. It's not a smart idea. Now, that having been said, some patients have preferences. Maybe they want to avoid medications, and I understand that. They want to minimize, synthetic treatments into their body. So we talk a lot about low-level laser light therapy, photobiomodulation, regenerative treatments in those cases. What can we do nutraceutically? How can we leverage things like, DHT blocking herbal supplements like saw palmetto, stinging nettle, green tea extracts, and things such as that that can really help the patient. Even curated supplements like Nutrafol and Viviscal. I'm not opposed to using those things, but we track it all, so we know what's going on. But a patient who says that they want a hair transplant without ongoing therapy, those are special cases. If you have an injury or trauma to the scalp and you need to fill that in, or you have a scar from a facelift or something, obviously that is not going to grow hair on its own. You need a transplant to fix that.
Of course.
You have a birth defect that's been removed. We replace the scar with hair. You replenish that area with hair, obviously.
How about post a transplant? Sometimes I've heard in some practices that they continue to do, say, PRP after a transplant. They say it really helps to maintain the new hair follicles and prevent any future loss.
Yeah. Well, the only patients that don't get PRP at the time of their transplant in my practice are patients that had it just a couple of weeks ago, meaning that everybody has PRP at the time of the transplant or around the time. Sometimes it could be a month or two before, let's say if they were in the office and then they decided to do a transplant in a rapid fashion. We use PRP routinely with transplant surgery. I think it's included with every procedure starting in this year. So it's a common process. The question really that we have for the patients is, what are the other therapies you want to add to your PRP? Do you want to add exosome therapy to that? Do you want to add PDO, polydioxanone? Do you want to start a TED regimen to kind of stimulate the hair follicles faster? And what is your hair homework, right? Are you going to be using a laser light therapy device? Are you using nutrition and nutraceuticals? What kind of medications, if you're, so inclined, what are you going to be doing after the transplant? Well, all of that is discussed at the time of the consultation, actually, and a treatment plan is provided. So, I don't have too much of an issue. Some patients fall off the wagon. Look, I can understand. You're deployed somewhere. You're stuck someplace where you can't get to therapies and treatments, and we have to restart your regimen. And it's okay. But everybody gets that education that they know in the back of their mind, transplanted hair is permanent, but your other hair is not.
Exactly. So you mentioned PDO quite a few times. Could you share with us about PDO threads and how it works? What kind of outcomes you've seen with this?
Yeah, so PDO stands for polydioxanone, and I'm a general surgeon by training, 25 years ago, 30 years ago. We used PDO as a slow absorbing suture material in the body, usually a deep stitch or mesh of some sort. But today, PDO is very common in cosmetic treatments and procedures because it can help with resurfacing, it increases blood flow, it increases collagen production, it's used for wrinkles. Some of the more clever people can use them to kind of pull and redrape the skin, although that's a tricky bit of business, so be careful who you go to for that. And it was about 6 or 8 years ago, someone said to me at an international conference in the Far East, they said, "Hey, did you ever try PDO in the scalp for hair growth?" I'm like, I no idea what that is. What are you talking about? I thought it was for wrinkles. And they said, well, in Korea and India, they've been doing it. And so this person told me about how, I guess, serendipitously, something happened where they placed a thread into the temple area to do some kind of draping, and they had an increase in hair growth in and around the area where the threads were placed. And so I decided to try it. Of course, the way these things work usually is family and friends. I talked to people who had been experts or were experts in placing PDO into the skin, not necessarily the scalp, but the skin to see, how these procedures were done and so forth. Got some training, got some expertise. I got good quality threads, and we again did that pilot study with some friends and family. And the first 5 or 6 patients that we did, and it was pure PDO. We did a few patients with the temples. We did men with some thinning in the mid scalp. We did some women with some thinning and men in the crown. And every single patient at 12 weeks had a dramatic improvement on the photos. It wasn't even like the measurements were changing, but the photos looked great. And I was like, oh my God, there's something to this. And so then around that time, we were also looking at the clinical literature, and I was seeing those case reports that were coming out of India and South Korea. And also there had been some interesting studies on mice, on the effects of PDO, which kind of explains, how the release of growth factors and so forth and the skin responds in terms of a slow, non-inflammatory healing process that basically somehow triggers the hair growth. And today we're still not 100% sure, but we know that there's growth factors that upregulate when there's hair growth and downregulate when there's a decrease in hair senescence. So we're seeing some nice signs in the clinical literature and the laboratory literature on why PDO might stimulate hair growth. And so, but I'll just impart to you this kind of funny end of the story. I was destined to present on this material at a conference, a cosmetic surgery conference, cosmetic dermatology conference, and I did a presentation on the PDO results, and I did a presentation on PRP, and then we were supposed to have a live demo. And so originally I had 2 patients, one for PRP and one for PDO. Well, one of the patients didn't show up, and so I had just one patient, and so I demonstrated both the PRP process and the PDO on that patient, and I will tell you that patient had results that far exceeded all of the other patients who were originally in the clinical trial. So in some way, serendipitously, that's how we came up with this process called PDO Grow. And so that's the kind of the recipe, if you will, using a high density PRP plus the PDO threads together. And that's been our therapy. So patients don't typically come in just for the threads on the scalp, but we usually do PRP with that, right? 99.9% of the time.
Sounds like the synergistic effect really worked.
Yeah, well, it was synergy, but it's also serendipity because I maybe would have gotten to that endpoint eventually, but not at that moment because we had just completed the pilot study. So,
do you find that
those results were amazing?
Is there a specific type of patient who comes in to the office that you think is a really good candidate for PDO Grow?
Yeah, absolutely. So those are typically patients who are in the earlier stages of hair loss, who are trying to maintain the quality and the quantity of the existing hair or boost the quality of their existing hair, protect themselves from further hair loss. If the follicles are dead and gone, and we can see that either with microscopic evaluation or just with the naked eye that they have a deep receded hairline, obviously the threads and the PRP are not going to bring back a hairline. Right? So we know that eventually those patients are going to need some degree of transplantation. But many of our patients who have been doing PRP year after year after year for so many years wanted something improved, new, better. And so PDO is a very nice option to kind of get them to that next level without any additional risk factors.
Is it painful?
No, we use the same ring block, right? It's a
Okay.
painless ring block. Ring, for your listeners who are not sure, it's a ring around the scalp. So it's a ring of injections that you don't feel. And the reason why you don't feel those injections in and around the scalp is because we use a vibration tool, nitrous oxide or Pronox on demand, and a couple of really clever techniques, maybe even a robotic syringe to deliver a painless injection. And so if you can deliver a painless injection of local anesthetic, guess what? You got a little numb spot. And then you use that numb spot to extend the ring. And
And
so,
what kind of
uh,
anesthetic are you using?
so I've been using, interesting question. So I've been using Septicaine for almost 20 years, and that's a little bit unusual. Most people use lidocaine and so forth, bupivacaine. Septicaine was introduced to me by a dentist who had some experience in Europe, and he said, "Well, hey, if you're using lidocaine, you should really try Septicaine." And it has a great safety profile, same as lidocaine actually, but I found it to be so much more profound and so much longer lasting, just clinically in the scalp. I couldn't even believe it. We've never gone back. It's a little bit more expensive than traditional lidocaine. It comes in
But it's
carpules.
worth
I
it.
use dental syringe. Oh my God! I mean, we never ever run out of Septicaine. I mean, we always have Septicaine on hand because it's so much better than the traditional um, local anesthetic that we would use.
Are you using the
Yeah.
same thing for hair transplants as well?
Yeah. So when patients come in and they have a painless PRP process or PDO grow process, and they might be considering a hair transplant, they say, "Wow, is what I just experienced the same level of discomfort as a hair transplant?" I say, "You have the exact same local anesthetic. Like your scalp is numb enough right now to do a hair transplant." And I think it's important to like not hurt your patients. I mean, I'm sure you feel the same. But the weird thing is that over the years, whether you're a dentist or a doctor or whatever, some physicians and dentists are just like not really keen on keeping their patients comfortable. But I think that that would be a struggle. If you want your patients to come back or to spread the word about your practice, you better provide a nice experience for them.
Also, I think it's very helpful for them to say, oh, I know what I'm about to get myself into. If I'm going to get a hair transplant, this is how it will feel. So, you also
Yeah,
mentioned exosomes, and I would love to hear your opinion on the thoughts of the safety of it. Do you have any concerns about the risk that they could pose potentially to patients? So, I'm just very curious on your opinion because I know this is a
yeah,
relatively new
sure.
therapeutic option.
No, absolutely. Exosomes is an exciting topic, and we could probably spend an entire hour talking about exosomes. In fact, they do spend entire days talking about exosomes at conferences like the World Stem Cell Summit, where you have not only researchers and clinicians, but also regulators like the FDA and Peter Marks and so forth, who are basically presenting material on exosomes. And so, just for the uninitiated, exosomes is an amazing technology that could be diagnostic and could also be therapeutic. And basically, what we're talking about are nanoparticles, right? We're talking about small bubbles, if you will, that used to be considered cellular garbage. That's how I was trained, that these exosomes that were given off from cells was just like the waste apart, it was like the sewer that cells didn't need. They would just give off these little bubbles of waste products. But obviously, we were wrong. These exosomes, especially when we talk about stem cell exosomes, are the carriers of messages, important messages for tissue regeneration and repair. And so, yes, you could do a liquid biopsy in your blood for cancer exosomes and hopefully maybe diagnose a cancer that hadn't been caught on MRI yet because of its size. And exosomes, again, are super small, 1/1000th the size of a cell, and so tiny that oftentimes they're hard to measure in terms of how many you have, and are they particles? Are they truly exosomes? Are they little bubbles? Are they little bits of something else? Sometimes it's difficult to know.
Right.
Especially these exosome companies may not have great equipment when it comes to evaluating their own product. So I think about exosomes like I think about stem cell therapy. And as we know, stem cell therapy has been around for a long time when it comes to orthopedic usages. That's how I learned how to do it from my orthopedic colleagues 20 years ago. And when you put stem cells, let's say, into an injured joint, like a knee or something like that, we know the stem cells don't become the knee. They're not like replacing the cartilage. They're not. But what they are doing is they're sensing the local injury, sensing the environment, and they're giving off messages to repair. right? They're like the general contractor. They don't lift a hammer, but they tell everybody what to do. Okay. And so when we're talking about exosome therapy, that could be therapeutic for skin or for wound healing or any kind of tissue regeneration and hair regrowth. We want specific exosomes that come from specific cell types. And mesenchymal stem cells are great sources of exosomes, but you have to have the right cell type. You have to have the right environment. You have the right collection protocol, because how you collect those exosomes also determines how well they work. And there's been a lot of data and information in the clinical literature, like you could have the same cell line, but if you collect them two different ways, you have a different therapeutic effect. And that was a lung study that was done years ago. So there's a lot of unknowns. But what we do know is that the FDA has not approved any exosome therapy, that they would prefer to use it topically, which is what we do. And so I would caution anyone undergoing exosome therapy to be clear about what they're getting and from what, if they're going to use exosomes as a practitioner, or if you're a patient going to get exosomes, you need to go to someone who knows what they're deploying, where those exosomes came from, what cell line, because it's a wild west right now. And I think you'll see more and more regulations. The FDA has, triggered a lot of warning letters out to people about what they're claiming exosomes can do. I think this area of medicine holds a huge amount of promise, because when you give microRNA and mRNA, you're basically giving the cells instructions on what to do. But what I have seen is that properly curated and deployed exosomes decrease inflammation in the skin. They can accelerate wound healing and accelerate hair regrowth after hair transplantation. They can be used as a standalone therapy. They can be used along with the transplant. We've used them on the skin. We've used them as a bath for the grafts during the transplant process. So I'm very bullish on exosomes. It's exciting technology. I've tried literally dozen different types of perinatal biologic and exosome products. So I have a whole spreadsheet, but I can tell you that what we've seen, the more recent ones that have come available, are far more concentrated and far more powerful than the ones that were available just a couple of years ago. So it's exciting. We'll see. I think it's appropriate to be skeptical of these kinds of therapeutics, because just like PRP, it's not standardized. And so you have to go to a practitioner who is an expert, and you have to know what's being deployed, if you will, topically onto your scalp.
Is there a particular place that you're getting your exosomes that you would recommend?
Well, I don't like to recommend specific brands on these kinds of interviews. I can just tell you that we're very, very careful who we work with. There are several brands that we use that are excellent. And, people can contact me directly if they'd like more information about that. And maybe that's a topic for a separate discussion. But, a lot of these brands are obviously under very close scrutiny. Because none of these brands are FDA approved yet. But I will tell you that the brands that we work with are the ones that have IRB controlled, clinical trials underway, whether it be for COVID or other things, and that they have, these INDs that are set with the FDA. So new drug investigation studies that are happening. So I think you're going to see a lot of interesting data and science, and it's just a matter of stay tuned. While we work all
Sounds
of
like
these
there's
things
a
out.
lot to come with exosomes. Do you do any fat grafting to the scalp?
So I have used adipose as a source of mesenchymal stem cells in the years past. We do a lot less of that today, but back prior to 2016, 2017, before the FDA guidelines came out, we were using SVF as a treatment for scalp, and I saw great results with that. The main downside is that you'd have to go after the adipose tissue, so a little, lipoaspirate, to get the adipose that you need. And you have to have the proper equipment to spin it down in a sterile container. Obviously, it has to be all done, some of it under a hood and so forth. So it was quite a bit of a processing protocol that we followed anyway in our practice, a closed system. And, to get to the SVF. But obviously that's not going to be a treatment that's really viable, I think, at least not here in Florida in the near future. But I did see great results with that. And that's one of the things that encouraged me when it came to exosome therapy. Because here, if I can provide the same kind of results from that kind of SVF stem cell therapy without having to go after those adipose, maybe in a more consistently controlled, deployable product topically, let's try that. And that's been pretty exciting.
Seems like it could maybe be a future replacement for fat grafting. And I just want to also touch quickly upon, do you recommend to your patients to use red light therapy, like a helmet after having a transplant or even leading up to a transplant?
Oh, absolutely. So I'm a huge advocate for photobiomodulation. But I have to say, back in 1999, when I got my first in-office unit with 60 little diodes, that was, a big 6 foot tall device, looked like a big hair dryer. I have to admit, I was a little skeptical. And actually, um, I was a loner because I wasn't a believer. And the more patients we put under that treatment, week in and week out, the more hair growth we saw. And I was blown away because, in medical school, they did not teach me about photobiomodulation. I didn't have the opportunity to get to know Dr. Michael Hamblin, the godfather of photobiomodulation. I didn't read about Andre Mester and how he grew all that hair on the backs of rats. So all of that had to be postgraduate training, meaning that on the job, right?
Right.
So I learned in the early days, we didn't even know how red light therapy worked. We didn't know that the mitochondria were the photoacceptor molecules in the electron transport chain. We didn't know that there was ATP production that was improving and increasing. We didn't know why there was less inflammation postoperatively. We didn't know why there was more blood flow to the scalp. I could feel the pulsations in my scalp when I used red light at home at night. We didn't have all those explanations, but Dr. Hamblin, he's my red light mentor. And in fact, his research helped develop some of the things that we use to help traumatic brain injury in my nonprofit that takes care of military veterans, and those photobiomodulation beds that you see popping up everywhere now in their spas and salons and homes and things like that. So the long story short is that we even used the laser comb originally when patients couldn't come in to the office, and if they were diligent, they got results with that too. And I looked carefully at those clinical trials and saw the improvements, and I measured the hair growth myself with these measurement tools and trichoscopy to see exactly what was happening right at the level of the scalp. And what I learned is that red light therapy can be a great adjunct to any kind of hair regrowth regimen. So if you want to stay non-chemical, you need a turbo laser cap. That is the latest and greatest device for at-home red light therapy. It's portable, powerful. It's been a redesigned, reimagined version of the original laser cap by the original inventor, Dr. Michael Rabin in Cleveland, Ohio. And it was a collaboration that was just amazing to deliver something that's so powerful in just 5 minutes a day. One-time cost, your least costly treatment over time.
Right.
And nearly all of our patients are excited about laser therapy because they get laser before and after their transplants, every time they come in for a post-op visit each day. And then, of course, they see the results in our patients who are using red light therapy as a standalone treatment for their hair regrowth. So it's been super exciting to be on the cusp of that technology. And, I can understand, again, the skepticism. It seems kind of gimmicky, you're putting it on this thing on your scalp. But, man, does it have an anti-inflammatory and pro-hair growth effect? You betcha. Great.
And how quickly after a transplant can they use this helmet?
Oh my gosh. Well, we have the in-office units that we treat immediately after the procedure. I actually have small units that treat the follicles while they're in cold storage before they're implanted, while they're sitting in the hypothermosol and the other solutions or exosomes. And then immediately after the transplant, when they come back in, the bandage comes off. The first thing we do is laser them with the red light therapy device in the office. And that night, they can go home and use their turbo laser cap.
Wow. Okay.
Just
Well,
have to be careful.
Right. Yeah, that's what I was figuring because the follicles are still, maybe for the first 5 days, you want to be a little bit more gentle, right?
Well, the interesting thing about the turbo laser cap is that it has a size adjustable snap on it. So you can adjust the size so it just fits a little bit larger than the size of your scalp. And we could pre-measure this right before your procedure. And even with the swelling, make it a little bit larger, obviously. And it just needs to sit right down. And because the way that it's made, it's not going to damage the hair. And it has a treatment panel that goes all the way back to the nape of the neck. So it treats the whole donor zone. And I've never seen the donor heal more quickly than when you use red light therapy after the procedure, or more comfortably, actually, in terms of the healing.
Incredible. Well, thank you so much, Dr. Bauman. I learned a lot today. I'm sure our listeners did as well. And I hope to speak to you again in the future. I hope you enjoyed this episode of the Derm Club podcast. If you found the discussion today to be valuable, please subscribe and share. I look forward to seeing you in the next episode as we continue to delve into dermatology and skincare with the world experts.